A 17-year-old female patient comes into the unit with abdominal pain and complaints of both excessive flatulence and diarrhea. After further investigation, it was found that the patient is deficient in both iron and folate. In the end, the patient was diagnosed with celiac disease, which impacts approximately 1% of the Canadian population. However, what were the steps taken to get to this decision for the client?
Well, we looked into the patient's medical history, family history, and ran various tests.
And what kind of family history did we find in the patient with this presentation?
This patient was found to have come from European ancestry. This was a key finding as there is an increase in prevalence among those that align with this. Age ended up not being a key factor as this disease impacts various ages. Additionally, the patient had genetic predisposition to this disease as they had first-degree relatives with celiac disease.
Other than the aspect of genetic predisposition, what other risk factors for celiac disease were discovered in this patient?
Good question. This patient had type 1 diabetes as well as Down syndrome. However, those are not the only possible risk factors for celiac disease that may be found. There's also Addison's disease, Williams syndrome, Turner syndrome, selective immunoglobulin A deficiency, and any autoimmune liver or kidney disease.
Right. It's also important to note a few environmental triggers that can impact an individual, including early infections, the gut microbiota in infants, and the feeding patterns, times, and amount of gluten being ingested.
Exactly. Now, before I go more into this patient's case, should we take a moment to go over the pathophysiology and underlying mechanisms of the disease?
Yes, good idea. As we know, the etiology of this is an autoimmune reaction. This means that the beginning of this disease stems from the body attacking its own cells. The T-cell mediated autoimmune injury causes tissue injury to the small intestinal epithelial cells as a result of chronic inflammation, which is activated by gluten ingestion.
Exactly. And since gluten contains prolamines, the digestion of gluten releases prolamine peptides, which are absorbed in the intestinal mucosa. Once the peptides bind to human leukocyte antigen DQ2 and DQ8, it activates the body's inflammatory response. Damage is most severe in the duodenum as it has the greatest exposure to gluten.
Yes. Also, the injuries that you will see come from this disease include atrophy and flattening of the villi, crypt hyperplasia in the upper small intestine, which is when the glands between the villi become damaged and try to replace the damaged cells quickly, making them become enlarged, as well as malabsorption of most nutrients.
Bringing it back to the case we are observing, the clinical manifestations that were brought up by the patient during their visit were complaints of abdominal pain, diarrhea, and flatulence. It is important to understand what the cause is behind these symptoms. Thinking back to pharmacology, the diarrhea would be due to the mucosal cell destruction, which leads to inflammation and causes water and electrolytes to be secreted through the diarrhea. Also, all the abdominal pain would be from all the tissue damage occurring in the small intestine. Although it is not seen in this case, steatorrhea can be caused due to fat malabsorption in the jejunum.
It is also important to keep in mind as nurses that there are atypical manifestations such as peripheral neuropathy, secondary hypothyroidism, or loss in bone density due to unabsorbed fatty acids which combine with calcium. Additionally, calcium cannot bind to oxalate, which leads to hyperoxaluria. There can also be various deficiencies such as iron and folate due to the injured tissue, which would have been responsible for the absorption of vitamins and nutrients.
Yes, there can also be complications that should be monitored for. These include malnutrition and deficiencies due to the inability to absorb nutrients and vitamins in the small intestine, bone and growth issues due to the malabsorption of vitamin C and D in the small intestine, and hypoprothrombemia due to the malabsorption of vitamin K. And although more severe and rare, lymphoma should be monitored for, as it can come from those who either do not respond to a gluten-free diet or if one is not adhering to that type of diet.
Now, it is important to know that there needs to be some testing done to confirm that what your patient has is in fact celiac disease. For the case for this patient, she was sent for a biopsy of tissue in the small intestine, which ended up showing histological evidence supporting the presence of celiac disease. On this unit, if you or a physician suspects celiac disease, this is the first form of diagnostic testing that should be conducted. Eventually, the symptoms and histological evidence should disappear if there is no gluten being consumed. Other variations of testing can be done based on the individual patient, such as blood tests for levels like iron, or bone mineral density screenings, which could show if there was impaired strength to the patient's bones.
Once this patient was diagnosed with celiac disease, the next steps included treatment and management of the disease. One aspect of management would be to observe if the treatment put in place is working. This means certain labs may need to be obtained from the patient. For this patient, the same blood tests that were conducted previously were done again, as well as assessing their symptoms to discover if the treatment was working or not. For this patient and all patients who are diagnosed with celiac disease, they should be instructed to adhere to a lifelong gluten-free diet, which includes wheat, rye, barley, and malt. This treatment should help reduce the symptoms and tissue damage that would have been occurring. The patient in the case we have been going over came back after 6 months of adhering to a gluten-free diet, and her symptoms were improving at a healthy rate. This patient had also been suffering from a deficiency in both iron and folate, so supplements have been provided for those, and there was improvement seen in the blood work.
Sometimes you may find patients mix up non-celiac gluten sensitivity, which is a wheat allergy, with celiac disease. This means the patient and/or whoever is mistaking these two diagnoses for each other should be informed that they have similar clinical manifestations. However, the pathophysiology and etiology differs.
There are some common questions and comments asked by patients that are not accurate and should be corrected to ensure their safety. One is that a diagnosis can be made based off just a blood test. This is not true, and a biopsy should always be conducted to determine if the patient has celiac disease.
Another thing you may commonly hear is that it is a childhood disease. You should be informing the patient that this actually can develop at any age after the ingestion of gluten. You should also be educating patients that this can't be outgrown, and the gluten-free diet they will be put on after diagnosis should be followed throughout their lifetime.
We hope this case study helped give you all perspective into the kinds of cases you will be seeing on our unit and what steps should be taken.